Thank you very much, Peter. It's a pleasure to be here from Liverpool and to join you for this session. So I'm going to set the scene by talking about non-unions in children's limb fractures and to look at some common denominators that I can share with you perhaps that you can take into your practice. These are my disclosures. Okay, let's look at the facts. Non-unions in adults. How common is it? This was a fairly interesting epidemiological study suggesting that if you look across 18 different bones in the human body in adults, the non-union rate's about 5%. And the risk factors to developing a non-union are shown in the slide. The severity of the injury in males who have a high BMI and who are smokers. If you were to compare them to children, we are taught from a very early stage that children are not small adults. As a consequence, non-unions should not be an issue, and the reality is perhaps not so different. The non-union rate across 18 bones in under 18-year-olds is about 1/5 that of adults. So what you see in your clinical practice, non-unions being less common in children than it is in adults, is true. However, when you look at the at-risk factors that predisposes a growing person to a non-union, they are virtually, in fact, they are identical to the predisposing factors to a non-union in an adult. Severity of the injury in a male with a high BMI who smokes. Children don't smoke, they certainly do. Children, particularly teenagers, smoke. And it's an increasing problem with severity of injury. We are taught that children have special qualities that allow them to avoid the problem of non-unions. We can see children bridging critical defects in bone that an adult would have no chance in doing. They heal faster, and we recognize that they have this ability to remodel. So why, despite these special qualities, are children developing non-unions, even though the rate is 1/5 that of adults? Well, the simple fact is these special qualities are all age-dependent. And you know from your own practice that the older the child is, the more likely these qualities diminish in their influence in healing the fracture. This is a study that we performed in Alder Hey Children's Hospital in Liverpool, and let me describe the two graphs for you. These are healing in 222 consecutive tibial fractures. And on the x-axis in the two graphs, it's the age, and on the y-axis is the clinical union time. And there are two graphs, the left graph showing you low-energy tibial fractures, and the right graph showing you the high-energy types. All I want you to recognize is that these box and whisker charts show you that the median time in clinical union increases with age. You can see it in both the low and the high-energy fractures. But what is even more important to recognize is that the spread of healing times increase with age, showing you that the older children are having much greater variations in their clinical union time, particularly with high-energy fractures. So, if you are to face this uncommon scenario of a non-union in a growing person, ask yourself this simple question: why did it fail to heal? If you start the problem by asking the right question, you're more likely to get to the answer, rather than look at a non-union and say, oh, well, that was a plate that was used, I'm going to use a plaster cast, or I'm going to use an elastic stable intramedullary nail. No, stop and ask yourself the question, why did it fail to heal? If you take some of the knowledge from the adult practice and port it to the pediatric practice, you recognize that non-unions in adults are arising because of 3 broad factors. There's one about insufficient control of the biomechanical environment at the fracture site. The second, there is a problem with the biology and the viability of the healing tissues. And finally, overwhelming influence of patient factors. So you can look at this triple etiology of non-unions as something to do with biomechanics, something to do with biology, and something to do with comorbidities. So these three factors can even be ported to the problem in children. So when any or all of these factors are present, your job is to identify them and reverse that problem. So go back to my tip. When you're faced with a non-union in a child, ask yourself this question before deciding what you want to do. Why is it failing to heal? So let's look at the first broad section on biomechanical issues. And the simple acronym that I would propose that you use when trying to work out why the fracture is not healing from a biomechanical sense is to use this acronym CAS. Is there sufficient contact at the fracture site? Now we know even in pediatric practice, and when I mean contact, I mean bone-to-bone contact, that if you have interposed soft tissue in a child's fracture, you can have a delay in healing. We know when a thick periosteal sleeve is interposed between fracture ends, the two bone ends don't heal. In children, there is a lot of cartilage around. If you have a physeal fracture that is not accurately aligned, you may have cartilage against bone rather than bone against bone. There again is a problem of contact between bone. Alignment, stability, and stimulation apply to all fractures. Of course, you can heal a fracture that is not well aligned. For instance, you can get malunions. But if you have a fracture that has good contact, that is well aligned, you have the best control of the strain environment. So alignment, stability, and stimulation go together. What about biology? Look at the X-ray and look for evidence of viability. Is there callus coming from both ends of the fracture? And what is the quality of the callus like? Is the callus decent or is it deficient? Because that is a quality issue that can often be interpreted from a sequence of X-rays. And finally, look at your patient. Are there factors that are contributing towards that fracture not healing in a timely fashion? In the UK now, the activity and the leisure profile of children have changed so much that a significant proportion of children in the UK are vitamin D deficient. They don't go out anymore. Playtime for children is in front of a television monitor playing a screen. Might also happen in India. Furthermore, if children go and exercise nowadays, they do so in an indoor gym. Again, no exposure to sunshine. So be aware of that factor being present in the modern pediatric population. Compliance, and you may have a disease that is preventing healing. So, identify the factors and try reversing them. Let me show you some examples there we can apply this. So from left to right, this is a 14-year-old male with an open fracture that is grade 3A that does not require flap surgery to cover. At week 0, you can see it's a transverse fracture, so relatively high energy. There's plastic deformation in the fibula and the lateral view, but not in the AP view. And you can see that by week 4, there's some early callus formation. By week 16, also some callus formation. But this is a 14-year-old that I would expect to heal by 16 to 20 weeks. And if you look at the CT at 24 weeks, what do you see? Well, let's try the algorithm. Contact, yes, maybe on the lateral side, but not on the medial side. There is a gap on the medial side. The alignment is okay, stability with the fixator is okay, and this teenager has been walking on this fracture. So, what do I need to do? I need to address the contact issue. How best do you address the contact issue? You can simply fill that gap with some bone. So, change to bone grafting the medial defect. We altered the external fixator to a plate simply because at 24 weeks, this teenager was getting fed up with the external fixator. So we changed the fixation to another form of stable fixation at week 0, week 4, week 36 after. So identify why the fracture is not healing and choose choose a solution that reverses that factor. Here is another scenario, but a much younger person, a male aged 8, this time with a 3B open fracture. And you can see here you have a sequence up to week 40 when the fixator was replaced by a cast of deficient healing and loss of alignment. If you look at the CT, again, if you apply the algorithm, contact doesn't seem to be that good. There's a small gap. The alignment is lost. We've lost the stability because we're now in a cast, and the child is still walking despite being on the cast. So we have to address the contact, the alignment, and the stability. We performed a fibular osteotomy. We compressed the non-union side with an external fixator and then plated it with a lag screw. There was no bone graft needed because we compressed it to reduce the gap. That's week 10 and week 19 in an 8-year-old. So, can you prevent this in the first place? Well, the answer is you'd want to look at the risk factors that produce non-unions in children. So, look carefully at older children, severe fractures, male, and children with high BMI. Check that you can approach the fracture slightly differently, perhaps by minimizing the additional trauma that you subject to the fracture, because there are two types of trauma. That is the trauma of the incident itself, and there is the surgical trauma. I'll be finished in 1 minute. And I want to introduce to you the trauma graft. And this is particularly important in the older children and the adolescents. If you look at the incident trauma, the trauma that produced the injury, and the surgical trauma, it goes something like this. You have injuries that are low energy with a small zone, injuries with a large zone of injury, and injuries that are so bad that there is localized tissue death. Your approach to treating these injuries should be reciprocal. That in a small zone of injury, you can literally do anything you want because there's enough reserve in the repairability to tolerate even classic open reduction internal fixation in the classic AO way with lag screws. But once you have a large zone of injury, you've got to reduce the surgical trauma and look about less invasive methods. And obviously, when you have localized tissue deaths, you have to replace lost tissue by reconstruction. So I reiterate, ask yourself a simple question. Why did it fail to heal? Look for CAS, look for evidence of viability, look for comorbidities, then optimize the relevant factors to achieve union. Thank you.